What happened?
Hey, Justin.
Hello.
What is this? Hmm. Okay. I got your email. Let me pull up the PowerPoint.
Yeah.
Um, okay, now where did I put it? Lord have mercy. Oh, wait. Oh, I have it here. Okay. I was like, what did I do with it? So it's a relatively short PowerPoint. Fecal occult tests, colonoscopies. Okay.
Okay. I don't know if I'm pretty sure I sent you the right one because there's like 3 different versions of it because my instructors kept adding to it.
Okay, is it this one?
It should be the one that has
This one has
35 slides. Yeah, 35
like
slides.
okay. Okay. So I'm gonna pull up another. We'll use that one, and then I'll use another one that I have that has like notes on it as well. What? Why is it doing that? Okay. So slideshow current. Okay, so we know our digestive tract. Ooh, okay, it starts in the mouth. Okay, and then it starts in the mouth, and we start with our saliva. Okay, So our saliva contains pancreatic enzymes that help break down food and proteins. Okay, that's where everything starts, right?
Mm-hmm.
And then we go down, okay, to through our pharynx, okay, into our esophagus.
Mm-hmm.
And then we have something called our lower esophageal sphincter, and that connects our stomach with our esophagus, okay? Now, when that does not fully close, okay, our lower esophageal sphincter does not fully close, okay, we end up with conditions like GERD, okay, gastroesophageal reflux disease, where because it's not fully closed, a little bit of acid, right, comes through, and then it starts burning through the lining of the esophagus.
Mm-hmm.
Now, when that starts to happen, we end up with conditions like cancer. You can also end up with something called esophageal varices. So think about, like, when we talk about varicose veins, it's the same concept, but in your esophagus.
Oh, okay.
Okay. So, and the reason being, okay, that we end up with cancer due to acid, right, is because what's going to happen? As acid is burning the lining of our esophagus is not built, right, for acid to be in there. So what's going to happen? It's going to start damaging the esophageal cells. And so as the body keeps, having to repair this tissue, right, cancer cells are just normal cells that all of a sudden become abnormal, okay? And so that's why you have the risk for cancer, okay, esophageal cancer, with GERD. Because of that constant repair, there's overproduction of cells, right? And so then that leaves the door open for potential cancer cells, okay? Or sometimes with GERD as well, is the sphincter is slightly is closed, but acid is leaking out because we have too much acid production in the stomach.
Yeah.
Okay. And so that's when we give those antacids and stuff that we talked about in previous tutoring sessions, right, to lower that. We also have conditions like ulcers, and that can be caused by H. pylori, which is a type of bacteria, okay? And so then typically once we treat it, right, then we can get rid of those ulcers and things like that. Now, as we leave the stomach, okay, we have something called a pyloric sphincter, and that connects our stomach with our small intestine, okay? As we know, our small intestine, the whole purpose of our small intestine is to absorb nutrients from the food that we eat. And then as it passes our small intestine into our colon, then our colon or our large intestine absorbs the water, okay? And so know that there are three different parts to our large intestine, our small intestine, okay? Our duodenum, oh my God, why did I just draw a blank right now? Our duodenum, or duodenum, and our ileus, okay, or ileum. And so the proper way to remember that is DJ ileum if you ever get confused on what comes first.
Okay.
So DJ, so D, duodenum, okay, or duodenum, J, duodenum, and then I for ileum. So DJ ileum, and that will help you remember if you get confused with the orders. And then with our large intestine, that's broken down into several sections. So when we listen for vowel sounds, right, and we break it into quadrants, right, our left or right lower quadrant, right upper, right.
Mm-hmm.
We're listening to specific parts of the vowel is actually what we're listening to.
Yeah.
So our right lower quadrant is this. Okay, this is part. So here, you can't really see, but our there is a sphincter that connects our small intestine to our large right here, right into the cecum. Okay, and then this is our appendix. So what happens, right, is this can be filled with fecal matter, and our appendix becomes inflamed, and then it can eventually rupture, right? Mm-hmm. So that causes appendicitis. So when we're talking about that rebound tenderness, we're talking about an appendicitis. and that is our right lower quadrant, okay? And then as we go up, this is called our ascending colon, because it's going up, right? So it's going up. So our ascending colon starts from our right lower quadrant, goes all the way up to our right upper quadrant. And then as we move across to our left upper quadrant, right, this is our transverse colon, okay? Transverse, like a T. And then, starting from our left upper quadrant, going down to our left lower quadrant, okay, this is our descending colon, okay, our descending colon. And then our sigmoid colon is here in our peritoneal area, okay, and then we have our rectum and our anal canal. So our sigmoid colon, so when we do an enema, we're going into our sigmoid colon, and that's why we put a patient in the left Sims position, okay? And the reason it being left Sims and the leg is hiked up is so it straightens out the sigmoid colon.
Okay.
Okay. So I know we talked. So as we talked about, right? So before, our stomach, right, going into our small intestine. After that connection from that pyloric sphincter, you can't really see it here because the organs are in the way, but there our liver, okay, and our pancreas actually connect to our small intestine, okay, to the first part of our small intestine, okay. And so we know our liver, right, that helps store our glycogen, okay, and it produces bile, and then our gallbladder stores bile. And bile production is so that it helps us break down fats. So when somebody has a gallbladder removal, right, we have to make sure that they're not eating a large fatty diet, because if they don't have a gallbladder, right, to store the bile to help with that breakdown in fat. Okay. And then our pancreas, we talked about some of those enzymes, right, that start in our mouth, with helping down breaking down proteins and things like that. Okay. And then obviously our pancreas also helps with our insulin production. So we have some different diagnoses. We have an upper GI series, okay, and we have something called a lower GI. So our upper GIs, we're talking about our esophagus, and we're talking about our stomach here. Anything intestine-wise, that's part of our lower GI tract. So if we wanted to look in our upper GI, where our patient's going to be sedated, and we're going to put a scope into their esophagus, and we're going to look into the stomach. We're going to look in the esophagus, and we're looking for things like cancer, ulcers, okay, any type of obstruction, okay, things like that. A colonoscopy is going to be for our lower GI series. So it's, again, our patient's asleep, okay, they're sedated, and it's literally a scope that we're putting into the colon, right, the large intestine, and again, we're looking for things like cancer, polyps, obstruction, right, any type of trauma, okay? And we can do something called a barium swallow. Literally, our patients swallow the barium solution, right? And then we go ahead and see if there's any abnormalities. Occult blood in stool. We're just taking samples of the stool, and we're looking for blood inside. Okay, that can be an indication of cancer as well. Okay, and that's basically part of our stool culture. That's something that they look for. But our stool culture, if there's not just blood in the stool, but fat, okay? You can have fatty stool and things like that. And then our stool color can tell us. You can have clay-colored stool, okay? And with a barium swallow, that's something we have to tell our patients. That they are it's going to come out in their stool. So if their stool is clay colored, it's okay. Or pale looking, it's okay. It's the barium. It's nothing to be worried about. If we have black tarry stools, yes, that can mean that there's blood in the stool, but that also means that maybe the patient's taking iron supplements.
Yeah.
So we have to be mindful that if we see black tarry stool, let's not freak out at first. Okay, are they on iron? If they're not, then we're going to kind of freak out.
Okay.
And then anything like coffee ground emesis, right? We know obviously that's we're vomiting coffee grounds.
Yeah.
We know that's a medical emergency. There's blood in the upper GI tract because they're vomiting it out.
Mm-hmm.
So here's kind of like an endoscopy. I'm sure that they went through this with you guys.
Yeah, the videos and everything.
Right. Colonoscopy. Okay, so disorders of the mouth. So remember, the mouth is our first start for digestion. So dental caries, that's all that means is cavities. Okay. The same thing. We can have candidiasis and carcinoma. Okay, these are extreme dental plaques and cavities. Okay, this is candidiasis. It's a fungal infection. A fungal infection. We also call it thrush or oral thrush. Okay, people with leukemia, newborns can have this. This is really seen in alcoholism. Okay. Some people with corticosteroids, immunodeficiency, like people like with AIDS, this is fairly common, okay, or HIV. People with chemo can have this, okay, because it's an infection, right? So it's an overgrowth of fungus and bacteria. So that's why people with immunodeficiencies, things, and like leukemia, certain cancers, right, HIV, can develop this very easily, okay, because they're immunosuppressed. Corticosteroid inhalants, so we're talking people who have asthma and they've been prescribed corticosteroid on top of an inhaler, okay, this can happen as well. So we're going to give nystatin, okay, we're going to give it can be painful, so we're going to do lidocaine oral solution squishes, okay, and definitely hand hygiene, soft toothbrush. We're going to avoid anything super hot, overly cold, spicy, or salty foods, okay, because it can just make the problem a lot worse than we need it to be. So this is what oral carcinoma, so this is a cancer lesion on the tongue, okay. This can happen with smokers. Okay, if there's a family history, if there is cancer in the body, okay, and it can spread to the mouth. Okay, these are the things that we can look for. And it very easily, that oral carcinoma can go into the jaw, into the bone. Okay, and it can spread to bone cancer. Okay, so we talked about GERD. I talked to you a little bit about how GERD happens, right? That backflow. So for some people, it causes heartburn, okay? But for some people, okay, it can feel like they're having a heart attack.
Yeah.
My grandma has GERD. She has to take omeprazole every day. And so we want to make sure that, she has to stay away from foods that trigger her. So green bell pepper, onions, really acidy tomatoes, right? Anything with like a red sauce. We went to the ER one time because she had a nectarine. I didn't even know that was high in acidity. Oranges, right? Things like that. So she has to be very careful, right? Because anything can flare it up. And so it's diagnosed with a barium swallow, okay, with an endoscopy, right? And then you can do an esophageal pH test because, again, we're not supposed to have high amounts of acidity in our esophagus. Okay, because it's not built for that, right? It's not built to hold acid. Over time, remember we talked about GERD can cause, right, esophageal cancer, okay? If it's not treated, okay? It can also cause hoarseness and sore throat because that burning sensation, okay? And so it's going to be difficult speaking and things like that because of the acid erosion, okay? Achalasia, okay, so this is basically narrowing, right? So it's like, there's a sphincter, right? But it doesn't fully relax. And so then what happens is the esophagus itself actually begins to dilate. So we want the sphincter to open and close, right? Like it's supposed to. But in this case, it's not fully relaxing. So it's not fully opening up. And so because of that, the esophagus doesn't it begins to dilate, okay? And it kind of like overstretches. And so that's how we end up with this condition. gastritis, PUD, stomach cancer. Okay, so gastritis is basically inflammation of our stomach lining. Okay, there can be a few reasons for this. It can be diet, right? It can be overproduction of acid as well. That can cause some gastritis. Most of the time, one of the common symptoms of it or causes is H. pylori. Mm-hmm. Okay, so we're going to treat it with antibiotics because it is bacterial infection. Okay, and this can cause loss of appetite because if your stomach hurts, right? And so what people are going to have, they're going to have pain in the left upper part of their abdomen because right on the left side of the upper part of your abdomen, that's where your stomach is. So that's where people are going to feel their pain. So it can cause nausea, indigestion. They can even vomit blood if the gastritis is severe enough. Okay. And obviously it can cause weight loss, right? They're going to have anorexia because they're not going to want to eat, right? If your stomach hurts, you're not in the mood to eat, okay? And then if we have chronic vomiting, remember that can put us in metabolic alkalosis, okay? Because we're constantly losing those electrolytes, right? So that's something we have to watch out for gastritis, okay? Peptic ulcers, okay? This can lead to bleeding and perforation, right? It's basically, a hole in the stomach, okay? And again, that can cause that coffee ground emesis that we talked about. That's a medical emergency. And then untreated ulcers can lead to stomach cancer, again, because just like that esophageal cancer, right? The body's trying to repair the tissues, right? So when we have a lot of cells, right, trying to repair constantly, then it really opens the door for one of those cells to decide, hey, I want to be a little wonky, I want to be abnormal, and then now we have cancer. Gastric surgery, this is for people with stomach cancer, okay? So they might have to remove part of the stomach, they may have to remove all the stomach, right? So then we have radiation, chemotherapy, and then dumping syndrome. And that's basically where, so remember we talked about that pyloric sphincter that connected our stomach to our small intestine? Yeah. Well, what happens is that pyloric sphincter basically stays open. So the food is literally not even getting into the, as soon as it gets to the stomach, it automatically leaves. Okay. And you're literally just pooping everything. It's what's called dumping syndrome. Your body's not, and that can cause weight loss, that can cause severe diarrhea, that can cause severe dehydration because your body's not absorbing any nutrients, no vitamins, no nothing. That can cause something with your intrinsic factors, so that B12, okay? Because of the dumping syndrome, and then severe, and dehydration, okay? So then this can put us, because metabolic alkalosis has to do with vomiting, so this has to do with diarrhea. So this can put us in metabolic acidosis, okay? Inflammatory bowel disease, so ulcerative colitis and Crohn's disease. So the difference between ulcerative colitis is there's some inflammation going on in the bowel, okay? Where Crohn's disease is there's inflammation going on through the entire GI tract, okay? The entire GI system. And Crohn's disease is autoimmune, okay? Ulcerative colitis is not autoimmune, but Crohn's disease is, okay? So they're essentially the same in a lot of how we treat and a lot of symptom-wise, but they're completely different in how they manifest. So Crohn's disease, right, difficult to pass stools. So both are going to have diarrhea, okay? We're going to have frequent bowel movements. They can even have bleeding with both, right? Because again, right, your rectum, it's very sensitive. So it's very prone to bleeding. So if you just have diarrhea after diarrhea after diarrhea, right, it can cause some skin integrity issues, right? And then if it causes skin integrity issues, that's risk for infection, right? Because you have fecal matter in an open wound. Okay. So, with with Crohn's disease, because it's autoimmune, we're going to give immunosuppressives.
Mm-hmm.
Okay. Our medication regimen is going to be slightly different, but pretty much the same. We're going to try to add bulk to the stool.
Mm-hmm.
And we're going to try to, and we're going to give some pain medication because this is, it's inflammatory. Like, it can be very painful. And it can even cause anal fistulas if we're not careful. People who have a stoma, right? So we're talking people who have, for whatever reason, right? You can have.
What's a fistula, by the way?
A fistula?
Yeah.
So a fistula. Here, let me see if I can pull up a picture so I can help explain it better. Why is it not? Okay. A fistula is. Hold on. Okay, I guess this will work. So basically, a fistula is an abnormal connection, okay, between two organs or blood vessels. So it can be either blood vessels or it can be between two organs. It keeps giving me anal fistulas, but sure, I guess we'll do that. Okay, here we go. This is probably the better picture because all the other ones are very.
I don't see anything.
And I know, hold on one second. I'm trying to. Okay, let me see. New share. Okay, here we go. Can you see this? Can you see the fistula picture?
Yeah. So it's just like a.
Okay, so you can see the picture, right?
Yeah.
Okay, so this is our anus, right? So this is where, our fecal matter is going to come from.
Yes.
And then here's the muscles right around your anus, right?
Mm-hmm.
So fistula, so see here, there was an opening between the muscle.
Okay.
This is a fistula. Basically an abnormal connection between two things, okay? So this isn't supposed to be there. This opening is not supposed to be there. This is supposed to be closed. It's supposed to look just like this side. Okay? But for whatever reason, right, a fistula was created. And so now we have another opening.
Okay.
Okay, so that's what a fistula is. Why did that lie to me? Okay. So it's like sores. It says fistulas form when inflammation causes sores or ulcers to form inside the wall of the intestines or nearby organ.
Okay.
That's why I kept giving me anal fistulas, but
yeah.
As long as you get the concept.
Okay, so yeah, it can occur anywhere, but okay, yeah. But it's mostly like towards like the organs, right? Just
Right. Yes. So it has to do with mainly organs, but it can also be blood vessels as well.
Okay.
So stoma care. So somebody either has a colostomy bag, right, where basically we have to put an opening into part of the colon, or you can have an ileostomy, so part of the small intestine. Okay, we have an opening in the small intestine, and an ileostomy there's a lot more water content. It's a lot more watery fecal matter because remember the large intestine is responsible for water reabsorption. That's why when we have stool, it's more bulky, right? Like we don't have a lot of watery stool, right? Unless you have diarrhea, but your stool is typically solid, right, for the most part. So. And that's because our large intestine, right, absorbed all that water. But when we have an ileostomy, right, again, it's a opening of the small intestine, okay? Ileostomies are more watery in nature because they have not reached the colon to reabsorb. So we have to make sure we assess for skin integrity around the stoma. Okay, there's certain powders we can put on the stoma to keep it to kind of keep it dry. Um, but we have to make sure that our patient isn't allergic to anything like that or adhesive because it's put together through like this adhesive tape, right, that we put over the stoma. Have you seen like a colonoscopy or
Yeah, I've been in clinicals. I've cleaned them up and everything.
Okay, so it's the exact same thing as a colostomy, except for an ileostomy. It's just the location of the back.
Yeah, I've seen both of them. I've seen ileostomies and colostomies.
Oh, okay, great.
Yeah.
So that's basically the same thing.
Mm-hmm.
It's just like I said, it's just location, but the care is exactly the same.
Yeah.
So we want to make sure that the stoma is not really red. We want it to be pink, but we don't want it to be red. We don't want it to be purple or black.
Yes,
right?
of course.
Those are medical emergencies. Call the surgeon. We're going in, right? Something's happening. Acute abdominal. So we talked about appendicitis, right? We talked about that pain, right? And we don't want to put any type of heat on there, okay? We don't want them strain or anything like that because then then the appendix can actually rupture. And when the appendix ruptures, then we end up, the patient can end up septic, right? Because all that fecal matter is now in the abdomen, okay? So diverticulitis. So to understand diverticulitis, we have to get into diverticulosis. And hold on, I'm going to pull up a picture real quick of diverticulosis. Okay, let me see. Oh, why did it do that? Lord have mercy. Okay, because I want to show you an image of what this looks like so you get a better understanding. Okay. Okay. So, what diverticulosis is, okay, is it's pockets in the intestine, okay? And so that's what diverticulosis is just pockets in the intestines, okay? Now, diverticulitis is inflammation of these pockets, okay? And so what that means is that our patients have to be uncertain. They can't eat seeds, nuts, things like that, popcorn, right? Because what happens, those things are hard to digest.
Yes.
And so they can fall into these little pockets. But so once they fall into these pockets, they can't get out. And so they sit there and they like rot. And they become inflamed, okay? And that's when we end up with diverticulitis, okay? So diverticulosis is when we have this presence of those pockets in the intestine, but diverticulitis is when those pockets become inflamed.
Okay.
That's the only difference, okay? So diverticulosis is the pockets, diverticulitis is when those pockets become inflamed. Oh, I did not need to stop sharing. Okay, there we go. Okay, so that's basically all that is, okay? And there can be bleeding as well, okay? There can be some bleeding into the stools, okay? Small amounts of bleeding, not large. It can be very painful, okay? There can be nausea, vomiting, and fever as well, especially if the inflammation is bad enough, right? And it causes an infection, okay? And it can cause constipation, which causes that you to strain and then you have that blood. But sometimes it can also cause diarrhea. So just everybody's a little bit different.
Okay.
Peritonitis is literally, well, let me see. So it's just inflammation here in the whole peritoneum. So in the whole abdomen area, okay? You can have something called fecal peritonitis. So remember when we talked about the appendicitis and rupturing? It can cause peritonitis because of the fecal matter. Okay, so inflammation. So you have really bad upset stomach, vomiting, diarrhea. You have reduced urine, a lot of belly pain, and feeling full and heavy or bloated. Okay, and your abdomen is going to be really, really tender because it's literally inflammation throughout the entire peritoneum. So hernias. So we have something. There's a hiatal hernia. Okay, and we have an external hernia. So an external hernia, or something like inguinal, umbilical hernia, femoral. So basically, what's happening is the organs are protruding, but the wall is still intact.
Okay.
Okay, like the abdomen is still intact. Let me see. I'm surprised they don't have like a side-by-side picture. External and hernia. I want like the live picture.
Let's see here.
Maybe if I just put hiatal hernia, maybe it'll pop up. Maybe? No? I was hoping it would show me like pictures on like a live patient. But nothing that I see that's like really promising. Okay, so okay, so a hiatal hernia is basically a dilation, okay, going on, okay, within, and an external hernia, so like an umbilical hernia. I'll show you. See how it's protruding out? It's protruding out.
Okay.
So this is what's considered an external hernia, where you actually can see the protrusion.
Okay.
Okay. Where with a hiatal hernia, it's more internal.
Okay.
So the patient's going to have all the same signs and symptoms, but it's more internal where you can't see it.
Okay.
Okay, so, and then an external hernia, you can actually, like, you can physically see the hernia. Okay, so colorectal cancer, second leading cancer cause of cancer deaths. Okay, so this is why colonoscopies are very important. And we do colonoscopies at age 50. Okay, starting at age 50, it's pretty routine, okay, for men and women, okay, to get a colonoscopy. And colonoscopies, just FYI, they have to drink this solution, and they can't eat anything, you just drink this solution. I've had two colonoscopies, and it's disgusting. They tell you to mix it with different stuff, like Crystal Light. It doesn't help. It's still disgusting. Like, the first time I did it, I mixed it with orange Crystal Light, and I couldn't drink orange juice or Sunny Delight or orange soda for like 8 years.
Oh, wow.
It was just because it was just my body remembered. It was disgusting. And you just poop your brains out. It's horrible. Like,
I see.
It's it's not fun.
Yeah, that's like it.
So with colorectal cancer, right, so obviously we use a colonoscopy, right, and so again, we're looking in the sigmoid colon, we're looking in the rectum, and we're looking for things like polyps, okay? If polyps are detected, right, we can have polyps that are cancerous, we can have some that aren't necessarily cancerous, and that we have to keep an eye on. So at this time, we can go ahead and we can actually take a biopsy.
Yeah.
Okay, we'll clip a piece of the polyp, and then we can go ahead and test it for cancer. Okay, so risk factors, those adenomatous polyps. Okay, so ulcerative colitis. Okay, so again, remember that frequent inflammation, that frequent repair of tissues, right? So again, all stuff like that, when we have to have the tissue has to constantly repair itself, it puts us high risk for cancer. Same thing with diverticulitis, right? Because all that inflammation, possible infection. And then obviously, hereditary, right? So genetics play a factor in that as well. If there is a family history of, say, colorectal cancer, then we're going to start screenings a lot earlier than 50, okay? Depending on what the average age of the family history is.
Okay.
Being overweight and obese can increase your risks. Alcohol consumption, tobacco use. People who have low fiber diets and a high fat diet, okay, or high in processed meats are high risk for colorectal cancer as well. So again, we want to make sure we're having, a well-balanced, not I'm going to say necessarily a high fiber diet, right, but a moderate fiber. If you're prone to constipation, then definitely high fiber, okay, and again, lowering that fat. Intestinal obstruction, okay, so we can have something called mechanical obstruction, which is basically like something physically occluding or blocking the intestines, okay? The non-mechanical is like if somebody, say, has surgery, right, or there's trauma and there's no peristalsis happening after surgery or whatever. So that's non-mechanical, where peristalsis just stops.
Okay.
Okay, we didn't do anything. There's no physical obstruction. It just stops. Okay. And obviously, when there's complete obstruction, right, either mechanical or chemical or non-mechanical, I'm sorry, we're not going to have any bowel sounds.
Yeah.
Okay, maybe there may be some bowel sounds in some quadrants and then no bowel sounds in others. But again, that's why we listen for that full minute, right? Because if we have absent bowel sounds, we need to notify to the physician. They may say, hey, they just came out of, anesthesia. Let's give them a little time, whatever the case is. Or they may say, okay, something happened. We have to go back into surgery. We have to figure out the problem. And just food for thought, not that you would ever be tested on this, an NG tube. So if somebody has a bowel obstruction, like a mechanical bowel obstruction, we can put an NG tube in and it actually helps.
Okay.
I'm not entirely sure about science on that, but I just recently learned that in one of my classes and I thought that was pretty cool.
Okay.
Fecal incontinence.
Yeah.
So remember we talked about our lower esophageal sphincter, and we talked about our pyloric sphincter, right? And then we also have a sphincter, our ileocecal sphincter, that connects our small intestine to our large, okay? And then we have our anal sphincter, okay? There's an internal and external one, and basically, and again, that's so what poop can, it opens up when we have to have a bowel movement, right? And so we can pass our bowel movement. But when we have fecal incontinence, right, just kind of think of like that GERD, right, where that lower esophageal sphincter isn't fully closing all the way. With this one, our external sphincter may be a little bit too relaxed and it's not closing back up. And so then we have fecal matter leaking out, okay? This can also be laxatives as well, okay? Overuse of laxatives can cause problems with our sphincters because so if somebody's abusing the use of laxatives, it basically tells the part of your brain, hey, I need to poop. It shuts it off.
Yeah.
And that's not reversible, by the way. Oh, wow. So our patients are going to have to keep taking laxatives for the rest of their lives in order for them to poop.
That's crazy.
Yes. So that's something that we have to watch out for. Things like multiple sclerosis, okay, things like that. Diabetes can cause this, and even like dementia. And a lot of that has to do with like neuropathy and just the like for dementia we're talking about because of the changes in the brain.
Okay.
And then over time this can cause distension of the rectum, okay? Or distension of the rectum can cause, so basically if you're always impacted. So picture somebody has chronic constipation. What's going to happen? that colon is going to swell and it's going to dilate.
Mm-hmm.
Okay. Same thing with the rectum, right? Because it's impacted. And so over time, it stretches out the sphincter, okay, and the rectum, and that doesn't go back. Over so much time, if it's constant like that, it doesn't go back, and that's where you can have fecal leakage as well. And that's kind of it for GI.
Yeah. Okay. Yeah, we had a pretty short week since we had the final, so there's no other thing. I mean, we're gonna have I think we also have the day off next week, so I don't think we'll have psych until 2 weeks from now.
What day do you guys have off?
Halloween.
Oh, okay. Oh, nice.
Yeah.
Okay. Well, I mean, at least you'll have some time to study. When's your final?
Oh, the final already happened.
Oh, it did. How'd you do?
95.
Good job. See? I don't know. See? You don't have to come to tutoring, bro. You're solid.
No, it's
I was
just,
like, I was talking to Roy about you. I was like, he's the only one that comes to tutoring. She was like, and he doesn't even need to go. I was like, I know.
well, like I just like to make sure that like I don't lose it. You know what I mean? Because like.
Oh, I love that though. I love that because it's true. If you don't constantly refresh your information, it's very easy for it to just kind of slip through the cracks.
Yeah. So. Yeah, I'm a repetition person. Like, I can't just like hear it once and then that's it. Like for it to stick, I need to constantly, be exposed to it, kind of.
Right. Do you ever record your lectures, like the teachers?
I mean, I don't even think they allow us to, but like.
You can if you ask. I haven't heard of an instructor that tells them no.
Yeah. I mean, I consider doing it, I guess, but yeah. For the most part, I'm just too busy, like, taking notes and all that. So, like, but yeah, I don't know. Maybe I'll do it when it's another teacher or something, and they're just going like a bit faster, and I don't know.
Yeah, I mean, I've never any ACC instructor. I don't think I've ever heard of any of the instructors being like, "No, don't record me."
Okay.
Even if you wanted to record me during tutoring, you're more than welcome to as well.
Okay.
I don't mind. I have a couple students who do that, and then they'll listen to my lecture, like on the way to school or on the way home or whatever to help it sink in. So,
Awesome. Okay.
But yeah, so let me know how everything goes.
Yeah, and hopefully, well, it'll probably be another short session next week. I don't know if you want to keep doing it, but the week after, I'm pretty sure like we'll have like more things to go over because then we'll have both Med Surg and psych.
Okay, yeah. Yeah, just let me know whatever you want to go over. I'm here for it. So if you have any questions, during the week, you can always reach out. And
of course.
But yeah.
All right. Well, thank you for tonight and everything. And I guess I'll just keep sending you what we have, and we can go over that.
Yeah, sounds good, hon. All right. Well, you have a good night.
All right. You too. Bye.
All right.